Welcome to Behavioral Health Today, a podcast brought to you by the Triad Network. This podcast is designed to share trending topics occurring within the world and our communities and bring them a behavioral and mental health perspective.
Welcome to Behavioral Health Today. I'm your host, Sharlee Dixon, and today I'm joined by Dr. Jorge Petit and Leah Harris. Jorge Petit is the Strategy and Development Officer at Zero Overdose, a national nonprofit organization focused on preventing overdose deaths. With over 30 years of experience in community and public psychiatry, Jorge has been a strong advocate for vulnerable populations, especially those affected by mental health conditions and substance use disorders. He has founded Quality Healthcare Solutions and held leadership roles at Coordinated Behavioral Care and Beacon Health Options, where he applied his expertise in mental health and substance use to drive impactful change. Leah Harris is a trainer at Zero Overdose, leveraging her lived experience with substance use and mental health to educate and empower others in overdose prevention. Prior to joining Zero Overdose, Leah worked with the Suicide Prevention Resource Center, the National Association of State Mental Health Directors, and peers envisioning and engaging in recovery resources. With over 20 years of experience as a speaker, trainer, and facilitator, Leah combines her professional background and lived experience to inform and inspire others in the recovery and overdose prevention fields. In today's episode, we're thrilled to be joined by Jorge and Leah from Zero Overdose to discuss a new and hopeful approach to overdose prevention. We'll dive into the transformative impact of their overdose safety planning specialist training, exploring how the program equips participants with the skills to assess and manage overdose risk effectively. With insights from both professionals and those with lived experience, we'll discover how this innovative training is changing the way we approach overdose prevention and saving lives. Thank you so much for joining us, Jorge and Leah. Welcome to the show.
Oh, thank you for having us.
So glad to be here.
Absolutely. So to get us started, can either or both of you give us a brief overview of what Zero Overdose does and the mission behind the organization?
Yeah, I'll start off. So Zero Overdose is a national not-for-profit organization that's really dedicated. Our core mission is about preventing overdose events and deaths through education, awareness, training, technical assistance. Our mission is really centered on providing communities, healthcare professionals with the necessary tools and knowledge needed to effectively respond to and prevent overdose events and deaths. We really emphasize a community-based approach, ensuring that resources and training are accessible to all who might be in any way, shape, or form at risk for an overdose situation, including families, first responders, healthcare providers. And like I mentioned in the last time we had a conversation, as a parent of two young adults, I am incredibly worried about sort of unintentional overdose and making sure that everyone, not just my kids, but the larger community is aware of what or how to be able to prevent overdose events.
Awesome. And so what really inspired the creation of overdose safety planning specialist training program?
So, I can also follow up on that. I'd love to, also turn it over to Leah to add some further color to this. But, this was founded by Tom McCary and Verna Little, who are both, amazing clinicians. They work up in the Hudson Valley area in New York in an FQHC. And really what they were seeing about 4 or 5 years ago was just an increased number of individuals that were coming out of jails and prisons with significantly higher rates of overdose. And they were worried. At the time, I think that they were really involved in trying to implement zero suicide, which is sort of a national framework around how to think about, preventing suicide events. And they wanted to develop a similar model and framework around how we're going to tackle such a significant problem like, the opioid epidemic. So they came up with this idea of thinking about, using a similar framework around early identification, safety planning, and develop some of these tools and created this organization to really try to disseminate further, some of the necessary foundational underpinnings around what or how to prevent, folks from having overdose events and deaths.
And so, Leah, from my understanding, you do a lot of the trainings for the program. Can you walk us through the structure of the planning specialist training program? And so what does a typical session look like?
Yeah, absolutely. So the training is about 90 minutes long, and we kind of start off with some level setting, taking a look at overdose trends, which when it comes to fatal overdoses, very happily, this is decreasing in the recent 6 months to a year We also spend time talking about fentanyl, a synthetic opioid that's driving a lot of the fatal and non-fatal overdoses that we're seeing. We also talk about new substances coming into the drug supply that participants should be aware of. We share the data that the vast majority, about 87% of people with opioid use disorder, do not receive any sort of treatment. And then we talk about that very, very frequently, around 67% of the time, there's some kind of an opportunity for intervention. So the call to action really here is that everyone can play a role in preventing overdoses, and that the overdose safety plan that we present in the training is a frontline intervention, which anyone can use. There's no need to have any particular qualifications, credentials, or letters behind your name. And then we actually go into what we call the overdose risk formula. And that's just sort of a framework for providers to have collaborative conversations about risk with peers or with clients, and to really understand better how to begin to assess overdose risk. And I'm glad to talk about that a little bit more. And then finally, we walk people through the 6 steps of the overdose safety plan, and we apply each one of those steps to a case vignette to help participants get a sense of what this might look like in practical application. So that's it. It's a packed 90 minutes, and we definitely get a lot of education in there.
I just wanted to sort of, piggyback on what Leah was saying, is that, we really are focused on this approach being very much, upstream, thinking about primary prevention in its true essence. The reality is, and I think, Leah mentioned, the trends are going down. I think a lot of that has to do with the fact that there's been such a saturation, of naloxone kits out there. We train people on how to use naloxone, but the reality is, if you need to use naloxone, it's kind of after the fact, right? You've already had an overdose event. So what we want to do is really be able to raise people's, understanding and awareness that, it's important to have naloxone. It's important to be trained around how to use naloxone, but we don't want you to need it. We want you to be able to know, if you're going to continue using, how do you use in a way that's safer and really prevents you from having an unintentional overdose event. So that's part of what we're trying to do, is really shift the focus of attention to be much more upstream and really empower people to have the necessary tools and skills and understanding and connections to, if they're going to continue to use in a safer manner, so that, they don't necessarily need to rely on naloxone.
Nice. And I really appreciate that the program doesn't necessarily focus on giving the training to mental health professionals. It really can be given to anyone. That's incredibly important, because we have people that are, experiencing overdose that don't have someone in their life that's a helping professional. So being able to train just the everyday layperson, I'm sure, is incredibly important. But I know what comes along with that is probably a bit more training involved in the risk of it. So how does the program prepare participants to really assess that and manage overdose risk effectively?
Yeah, absolutely. I can speak to that. So the training introduces this overdose risk formula. And we also have a companion risk questionnaire that talks about different kinds of variables, right, that people can use to assess overdose risk in themselves or others, right? So the amount of the substance that's being consumed, or its potency, right? So we're looking at that, like, how much is this person ingesting? The route by which the person uses the substance, right? Is it IV use, snorting, smoking, swallowing? We also talk about tolerance, right? And how that fits into the equation, right? We know, as George referred to, that people coming out of restrictive settings have a much more likelihood of overdose because their tolerance rate has been reduced by being in those settings and not having access to substances. And we know that as little as 48 hours, right, in a restricted setting can affect somebody's tolerance. So we really spend a lot of time talking about tolerance. We also talk about the mindset of the person who's using substances, right? Is it celebratory? I use the example of someone going out for a few beers on a Friday night, for fun, versus being driven by this desire, right, to anesthetize intense physical and or emotional pain, right? So we're kind of thinking about that mindset and how it impacts risk, as well as the setting in which someone uses substances, right? Who is with them? Are they alone? We know, for example, if someone is alone, right, that is a very dangerous place to be in, right? And it puts them automatically at a higher risk if they're using alone. Also, what's the environment like? Are they rushed or afraid? We use the example of somebody who, is using in, I don't know, like a public bathroom somewhere, right? And people are queuing up behind and knocking, and they know that it's just going to be a matter of time before the manager's called, right? So looking at all of these aspects of the environment. And that's just a brief snapshot of some of the ways that we can talk about gauging risk. We also know that once someone has overdosed in the past, they're at risk for a subsequent overdose. So we try to get a picture of that history as well as their health history, right? Because we know some chronic conditions such as COPD can put someone at higher risk of an overdose because these are conditions that affect breathing to begin with. And then once the clinician or the peer has had this collaborative conversation with someone about risk, then, we look at each one of those risks and we pair them with personalized strategies for preventing overdose, right? Those are actually the first two steps of the safety plan. So, for example, if someone's using alone, we might encourage them to have someone check on them or to call the Never Use Alone hotline, which will stay with you and call emergency services if you become unresponsive. And then the last thing I would say about it is, we should understand that safety planning is only part of the hopefully, ongoing integrated care and support that people at risk for overdose should be receiving within our systems. I mean, we also really work to support agencies and organizations to operationalize the safety plan so that it can be embedded in electronic health records, right? So it's kind of
Wow.
it's embedded in the system. And then the last thing is just we encourage these plans to be reviewed and updated regularly because they're not like a static one and done, but a living document that really changes as the client's lives change.
Nice, nice. I really appreciate that you are integrating it into healthcare, into the EHRs, because I'm currently a social worker in a dialysis clinic, and we have lots of other assessments, but we do not have one for overdose or substance use at all, really. And so that would definitely be helpful, as just mentioned that patients that are coming out of situations that have been restrictive are much more likely to have trouble in those areas. So I really appreciate that you're adding that into electronic health records. You mentioned before, Leah, that the training also includes some vignettes and being able to provide some scenarios. Can you share an example of how these exercises help participants build real world skills?
Yeah, absolutely. So I think we actually realized that we needed to iterate from our original 1 hour training to provide this more in-depth offering that is a little
Okay.
bit longer and includes the vignette because we were getting feedback and we take all of our training feedback very seriously that practitioners were seeking more of an opportunity to apply the knowledge and the skills they got in the training. So we added in a brief, realistic case vignette, which really allows the participants to go through all 6 steps of the safety plan, actually applying that in a theoretical situation with this young adult client, Jill, who's going to pill parties where people crush up and ingest a mixture of substances. And she's feeling a little uncomfortable about this. But we assume in the scenario that she doesn't want to stop going to these parties. She just wants to know how to be safer. So we go through, we actually walk through all together the steps of the overdose safety plan using this scenario. And I think that this gives them more confidence in actually applying this in real world situations with their clients or peers.
Absolutely,
Yeah.
absolutely.
What I'd like to just add to that is I think it's really critical, and what we've seen is that a lot of times folks have a hard time thinking about what are those mental scripts that you need to be able to have these conversations.
Mhm.
So with folks that are using, and perhaps again, the focus here isn't about abstinence, right? It's about ultimately how do we get to a safer place. But having these conversations, especially if you're in a healthcare setting, sometimes they're challenging, and I think that they bring up for many individuals this sort of trepidation around, am I endorsing? Am I condoning? Am I being complicit in suggesting, for example, that instead of injection, maybe they should snort? I'm still so I think the trainings and the case vignettes really allow for these types of conversations, because Leah and the trainers, are really masterful at being able to break this down into like more, specific components that allow the folks that are being trained to have a better sense of what or how they would approach it themselves, right? So I think
Yeah.
it's really critical to be able to provide that level of assurance that these are conversations that are hard, But again, we need to have those because what we're trying to do is prevent someone from dying.
Absolutely. And being able to practice it, or like you said, to have that mental skit or mental set of things that you want to say or questions that you think are relevant are incredibly important to being able to use it in real life when you need to, instead of trying to figure out, wait, how do I do this? How do I say this when it's happening? Absolutely. So you mentioned that you work with a lot of organizations and even some other participants, and that you take that feedback important. It's important to you guys. So what type of feedback have you received from your participants that have gone through the training? What do they say?
Yeah, thank you. This is really encouraging feedback that we're receiving. So far, 100% of learners think the content would be useful to their clients. So that's huge right there.
Yeah.
And 92% of them say they plan to use it in their work. So we're pretty proud of these statistics. And we get a lot of appreciation from providers across the behavioral health workforce, kind of saying, what George said is that this information is giving them more confidence, more specific skills, more ways to support their clients who use substances, whether their clients' goals are abstinence-based recovery or otherwise. Yeah, and just a lot of our feedback is along the lines of, feeling like they just feel more confident and empowered to support people at risk of overdose and to prevent overdose. And I should say we've also had some requests to pair overdose prevention safety planning with suicide prevention safety planning.
Hmm.
And we have been rolling out a training that looks at these side by side because there is a lot of overlap in terms of how you
Mhm.
do safety planning and even in, many of the risk factors and protective factors. But there are also some significant differences. And, just in part due to the fact that suicide is always characterized by degrees of intent, right? Whereas overdose may or may not be intentional, which kind of complicates the situation a bit.
We'll be right back after a word from our sponsor.
Whether you're a longtime or first-time listener to Behavioral Health Today, you're probably familiar with Triad, the company that brings you this podcast. But you may not know that Triad also hosts a community for current and aspiring behavioral and mental health professionals, featuring trending content and education and career resources, all for free. If you are a behavioral or mental health professional, or you're studying to become one, join more than 80,000 people on Triad by claiming your free professional account today. Visit us at hellotriad.com/BHT. That's hellotriad.com/BHT and join the Triad community today.
Absolutely, absolutely. So, George, I want to take just a step back in our conversation. I've heard lots of talk about overdose safety planning, but I'm not exactly sure what it is. So, can you give me a bit more details about what exactly overdose safety planning is, and how is it different from traditional approaches to overdose prevention?
Right. So I think, overdose prevention writ large is really sort of a way of trying to work with the individual on creating sort of a structure around what or how they're going to ultimately move through more traditional settings for management of their substance use disorder. Overdose safety planning, like I said, it's kind of born out of the experience, in suicide safety planning. It's really a very, very structured way of having a conversation with an individual, like Leah was describing in terms of our training, right? It's identifying what some of these risk factors are, and then working with the individual to be able to pair the risk factor with a safety measure. But the important thing about this, and this is why it's so critical that it's embedded into, the electronic health record, or ultimately it's available, as an app, is which we're working towards, is to really be able to have this iterative conversation around what my particular, risk factors are, and then what I need to do to be able to maintain safety around, continued substance use. So that's what the safety plan is. It's not dissimilar. And when you look at the way that we've structured, our safety plan, it will seem familiar to you if you're familiar with, doing this around suicide. So again, it's a structured way of getting at information that is really critical for an individual to have readily available, for a treatment team to have readily available. It is iterative. This is really very person-centered. It's kind of anchored on, some of the underpinnings of motivational interviewing, really helping an individual think about, well, what can I do and do differently, in these different scenarios that I'm laying out in terms of how I'm using and what can I do differently to prevent. I think the great example is, when we use, Jill at the pill parties is, if she's worried about what all these different pills be, it's like, well, maybe we need to have some, fentanyl test strips or some xylazine, test strips to be able to determine if there is that in the supply. So, there are things that we could do and we can work with an individual to help them do to ultimately get them to be safer. And then again, this is sort of like an engagement strategy. Hopefully over time, as we're working, with the individual, especially if we're in a healthcare setting, it's about getting them to be, safer and safer. And then hopefully, again, we're not pushing for it, but hopefully we're getting them into more, more traditional interventions, whether that be ultimately getting on, medication assisted therapy or other types of interventions that will help them with their substance use disorder.
Got you. And so it really does sound like the training does a good job of really discussing that intersection of behavioral health, medical wellness, substance abuse disorders. Can you speak to that combination or that intersection a bit more?
For years, right, we've siloed, right? We think that, substance use versus mental health versus physical health versus, all the health related social needs like food and transportation and
Right.
housing are all separate and distinct. The reality is, we are one human being with a whole bunch of, issues that are going on. And the fact that we've siloed, the care and the interventions based on how funding streams, which is exactly how it's and why it is the way it is nonsensical. So really our approach is very holistic, very comprehensive, very person-centered. It's about understanding the individual and where they're at and how and what can we offer, especially if you're talking about healthcare settings, what and how can we offer, that next step in terms of having them understand what's going on, have us understand what's going on, and then put these pieces together. Like when you look at the safety plan, there's a couple of steps in there about identifying, people that are within their circle that they want to, share the safety plan with or to reach out to. Obviously, it talks about their larger, touch points within the healthcare ecosystem or within the ecosystem, people that they should be, contacted if there's a situation, whether it's a healthcare provider, it's a housing provider, whatever it may be, right? So we're trying to bring in all of these different elements of an individual's lives that make for hopefully, safer and better conditions for them to ultimately, seek care and be safe. And then also lastly, one of our questions is, what are the things that I'm going to do to be safe? I mean, what's the type of, focus for me to continue to be alive? So we really try to tie this all together in a way that is meaningful and impactful for the individual. And again, this is not static. This is not a one and done. Like Leah was saying, this is something that we want to be working on constantly because, risk factors vary. Today I might be homeless and my risk factors are very different than if I got, I'm in supportive housing or I'm in a shelter or I'm back home. So, we really want to make sure that these things are ongoing and live documents that are going to change with an individual's life circumstances.
I also would just add another thing I really love about the safety planning is that it's put in the peer or the client's own words. This is really they're in charge of it. They're sort of it's the way they understand it and conceive of it is how the safety plan is laid out. So I really love that because it is so person-centered. And when we talk about meeting people where they're at, we use that a lot in healthcare, but this is what it actually means. So yeah.
Love that too. It's a big social work tenet. So I completely agree with you on that. Absolutely. So, in my small experience with substance use disorders and mental health disorders as well, I have found that it does tend to come across a little better to the participant or the client when it is coming from, or the care is coming from someone who's had experience. So, Leah, I understand that you have your own personal journey of recovery. Could you share a bit about your experience with us and how it inspired you to get involved in this important work?
Yeah, absolutely. I've been talking about my lived experience, and sometimes we also talk about it as lived expertise, right? For
Mhm.
a whole lot of years. So I'm an open book. I started using cannabis around the age of 12, 13 in the late 80s. For various mental health and substance use concerns and suicidality, I spent a lot of time in various treatment settings, including I spent a year in residential treatment during my adolescence. And what I remember from that time is the focus was always abstinence, right? No other approach was even on the table, right? It
Mhm.
was not even up for a chat. And when I was discharged from the residential treatment center, I was mandated to attend 12-step meetings for a time with like the threat that I could be rehospitalized if I didn't do it. And I'll just say that being coerced into treatment didn't work for me, and that's why I love this approach so much, right? Because it
Yeah.
is voluntary and it's person-centered and person-driven. After my mandated period of 12-step attendance was over, I just started using again with the kids I'd met in the meetings. That's what happened. And they introduced me to crystal meth. So I grew up in San Diego in the early 90s, which was then the epicenter of the crystal meth epidemic. And of course, my experience using meth then is very different from what people face now because this was the 1990s and we didn't have to really worry about fentanyl contamination yet. But it was still a pretty harrowing couple of years. I felt really alone in it because my friends had kind of moved on to riskier ways of using it, and I felt afraid. I didn't feel like I had anyone I could talk to about any of that, and some of the kids that I was in residential treatment center ended up overdosing in subsequent years. I've also lost friends to overdose since then. And when I first learned about like these prevention strategies, right, that are about, looking beyond abstinence, right? Abstinence is an option, but it's not the only option. I didn't have kids yet. This was maybe like 2000, 2001, but I swore I would raise my kids on that approach. So I have only one son, but I started talking to him about drugs and alcohol at a very young age. I was very open with him, age appropriately, about my own history. And we did have a harm reduction household. My son is going to be 20 this year, and we have such an open relationship. Like, he can talk to me about these things. He knows he's not going to be judged. And it's just very different than the kinds of adversarial relationships that I experienced with my family, like these, power struggles when anything short of total abstinence is considered to be a failure.
Yeah.
So I've been a huge fan of these emerging approaches for working with substance use. And as soon as I had the opportunity to train on these topics, I've absolutely jumped at it. And it's been incredibly rewarding to be able to share this information and to bring my own lived experience to it.
Awesome. Well, first, thank you so much for sharing your story. That's incredibly brave to do. And so thank you for sharing it. And then not only just sharing it in this type of arena, but using it to empower others to change the way that we see the world. So thank you for that. Thank you. Can you talk about how your personal experience has shaped the way you approach training others in overdose prevention, especially because you've had the experience?
Yeah, I think what I try to lead with in my training is that this approach is so much about empathy and compassion. When I think back to my teen years, I'm just struck by how much judgment I received while I was in care, which led to an enormous amount of shame that I still struggle with sometimes, right? And so
Yeah.
I want to convey to providers that these experiences, whether intentional or unintentional, they can really, really stay with you. Like I, remember the exact words that people said to me when I was 15 or 16 that hurt so much, and those are, burned into my memory. So I really, really continue to maintain, that substance use care should be voluntary, low or no barrier to access, and it should be free of all forms of judgment, stigma, and discrimination. And when I say this, I really do refer to my own history as a child of the 80s and 90s who grew up on the just say no to drugs
Yeah.
slogan, or this is your brain on drugs. I don't mind giving away how old I am, to explain this. Maybe some of you remember the Scared Straight program that would take children into prisons. That was like, this is your future if you don't stop using, right? So I
Yeah.
talk about in my trainings how demanding and shaming and scaring people, it doesn't work. It never has and it never will. What works is compassion and patience and applying these collaborative approaches that, yes, once again, meet people where they are. And we're not doing things to people or for people, but with people. And we're recognizing their own expertise in themselves and how they have survived up until this point.
Absolutely. So beyond hiring, how does Zero Overdose meaningfully engage people with lived experiences like yours? And why is that essential to the effectiveness of this program or programs like this?
Yeah, absolutely. So I feel our entire approach to overdose prevention is steeped in insights that have come directly from people who use drugs, right? From people who use drugs for people who use drugs.
Got it.
So from the outset, we're really recognizing that the answers, can't all come from on high in the academy. I mean, the academy is hugely important partner in this, but really what we need is a true partnership across systems and settings, with people who use drugs in the lead. And they often have some of the most innovative ideas. So, knowing that and building on that, we're really excited to be developing an ambassador program, which would be modeled somewhat on the community health worker model or the promotores, to teach people with lived experience to go into their communities and educate their peers and community members on this kind of information. So, and we do know, like you were saying, Sharlee, from the research, that these kinds of programs are really especially successful because people tend to listen to folks who have similar lived experience. And I think they are also really successful among the people who have whatever reason to mistrust health systems. Maybe they had experiences like mine. They might be reluctant to engage. So I think hearing this information from people who are from their communities can be so impactful. So I think as much as we can bring those lived experience voices and feet into our communities, right, that's where we're going to see even more of the change we want to see.
Absolutely.
Can I also just add to that, which I think is really important? And I think that what we tend to do is think about, let's say as a parent, right? My kids don't do drugs. I mean, I think we all feel, that we don't, they're not involved in anything. And the reality is, they may or may not be. And I think, putting our heads in the sands and thinking that, we're exempt from any situation is not the approach. And that's why I've been incredibly, same thing, as you were saying, Leah, I've been very open and vocal about these issues. We've been having these conversations for a while. I remember, I don't know, like 5 or 6 years ago, I actually, I used to work for the Department of Health here in New York City. I got some Naloxone kits. I trained my kids, and I made them take it in their backpacks, and they're like, going to high school with, they're like, Dad, this is ridiculous. But I'm like, look, if you can carry an EpiPen, you can carry, an naloxone kit, because it's sort of similar in terms of being, life-saving in the moment. And not that I will get no judgment around what or how, but we can't keep on thinking that, our kids and others are exempt from this, because the reality, I think, of the situation is such that, the supply of drugs is so adulterated, and what you think might be a Xanax pill that you're getting from a friend, or, Adderall that you got from your cousin, might be adulterated, and you can actually with one pill die. And I think that, without being catastrophic or being, scaremongering, I do think that it is important to be able to say, this is very different. And I think you need to be aware and have an understanding of what the risks are, and take a more measured approach to this. So I've been very, vocal about this as well, in terms of really being able to disseminate this information and start telling, parents, my kids' friends, parents, like, this is a problem and you need to be aware of it. And you could say, oh, my kid's fine, but you never know. So it's really about, raising awareness in a very different way.
Absolutely. I completely agree with you. As a parent, my children are younger. They are 11 and 5. And when you first said it, George, I was thinking like, gosh, I really haven't had that conversation with my 11-year-old yet. And is it too young? Like, where do you start? Like, slightly off topic here, but where do you start those conversations? And it's both for you, George and Leah, as parents. Like, how do you start that conversation with your children so that it doesn't turn into the shame, blame type thing?
Right. Well, I mean, you look at the data. I mean, they're vaping. I mean, there's all of these risks out there, and it's younger and younger, right? So we know this is happening. So for us to sit here and think, I'm going to wait until they're 18 to have this conversation seems, and I think every parent has to sort of weigh the risks of, or the way that they're going to approach this. I think there's ways to talk about, vaping. There's ways to talk about alcohol that are age appropriate, developmentally appropriate, and without it being, again, I think from this shaming perspective about, don't drink or don't, I think kids they're naturally going to want to experiment, and they're naturally going to be exposed to this. And you want to give them at least enough information so that they can make the right decisions in the moment, knowing fully well that they're kids and they might not make really good decisions, but at least, I guess, so for me at home, when my son was in 8th grade, so that would have made him, I guess, like 13, 14.
13.
Yeah. There was some, after school party. And I was like, no, you can't go. And he's like, Dad, but I want to go. And I'm like, all right, but if you are going to go, these are some of the ground rules, like in terms of thinking about what you might be exposed to. So, we had a conversation there, and we've had, subsequent conversations over and over again about, what the potential issues are, and how they're both boys, how they can actually remain safe without it being, seen as like, oh, I'm not participating, or I'm not, cool enough to be with my friends. So there's a lot of that I think you have to work through. I don't know, Leah, what your experience was.
Yeah, I feel like I just started having very informal conversations at a young age. I think my son was in 5th grade at the time, and yeah, I just asked him, "Have you ever had a drink?"
Okay.
And it turns out he had a drink, and we just had conversations about that. I would ask him things like, "What do you know about drugs?" And he would
Okay.
tell me what he knows, and then I would proceed from there. And then when he got older, I did tell him about some of our family history. Again, like George said, not as like a scaring tactic, but there are people in our family who have psychosis, there are certain risk factors when you have a genetic predisposition to psychosis. Using cannabis can be a much bigger problem than you think it will be. So it was just, in the means of sharing information. I never said you can't do it and this is what's
Okay.
going to happen if you do it, but just really sharing information, like helpful information. And also just really making it clear to me, I don't care if it's 3 in the morning, 4 in the morning, 5 in the morning, if you are out somewhere and things are going sideways, call me, text me, do whatever you need to do. Like, I'm not gonna be mad. Like, I've just really have made that clear, and, that did happen once, but it was when he was with his dad, so I didn't have to answer it. But, yeah, like, just really making it clear, like, there's not gonna be punishment and shame, shaming
Absolutely.
if you talk to us about this stuff.
Absolutely. Thank you both for kind of indulging me. Like I said, I was thinking like, gosh, as a parent, like, how do you do that? Because like you, Leah, I grew up in, 80s and 90s where it was your brain on drugs and, the egg and all that kind of stuff. And so that I don't know that that really worked for our generation. So I would not like to do that again. And I'm hoping that our listeners found that important and interesting as well. Thank you for sharing.
Mhm.
So, can you guys share a success story or an example of how the overdose safety planning specialist training has made a difference in preventing overdoses?
It's kind of hard to say, there's been, sort of this causal relationship between our training and, overdose prevention per se. But I think, what we do see is beyond sort of, the feedback that we get about our trainings is the fact that, many organizations want us to come back and do more training, or we've been incredibly successful at continuing to do, more and more trainings on more and more, levels within, let's say, an organization, whether it's peers all the way up through, the doctors, because I think that there is a recognition of the value add in understanding these issues and trying to embed this, into workflow. So I think, that in and of itself seems to, at least for me, it's a very positive indication that organizations get this and they want to further enhance their ability to be able to offer overdose safety planning to the people that they serve. So that's a success. What I would love to see is, the federal government saying, if we're going to be distributing naloxone, we should be ensuring that anyone that gets a naloxone kit also has, an overdose safety plan. We're not there
Mhm.
yet, but we're kind of moving in that direction. I do think that there
Yeah.
has to be, these levers of power, whether it's city, state, or federal, to really be able to endorse this as, a best practice. And in the same way that today, I don't think anyone would say, oh, why should I do screening and suicide safety planning if someone's at risk? This should be the same in terms of like someone who's at risk for an overdose should be, screened and provided an overdose safety plan as a routine clinical matter or a routine matter. So we got to get there. But I think that, again, sort of our ability to have expanded our training. We're now, I think, in 36 states. We're about to launch a huge project in Puerto Rico, I think is a testament to the success of overdose safety planning as an intervention that is really critical.
Awesome. Awesome. And so, along those same lines, how does Zero Overdose plan to expand? You mentioned moving into Puerto Rico and expanding it to further states. So, how do you plan to expand and adapt the training program to meet the growing challenges of overdose prevention in today's world?
Yeah, I think the possibilities are limitless. It's really more of, trying to just figure out like who the right partners are. So, we've been looking at doing more with first responders in terms of training. We're looking at, training youth and, college. That's a very different population. I think the training has
Yeah.
to be done in a very, specific and nuanced way. We're looking at opportunities to work with folks that are, in shelters, homeless population. So I think that, the possibilities are again limitless, right? I think that there's so many
Right.
different things that we could or should be doing. It really is going to be dependent on, where we can find the right partners, where we can figure out, the right funding for opportunities to be able to expand. But I definitely think different populations, different settings with different components of the healthcare setting, thinking about pediatrics, thinking about OBGYN, thinking about maternal
Mhm.
mental health is a huge and I think untapped resource in terms of, finding individuals who potentially are at risk. Pregnant women who are using are not necessarily, getting the care that they could or should be getting. And I think we need to do more around those. So I think we got to find the right, partners to be able to really embrace. And then what we've been able to do is, I think, tweak our trainings to really meet the needs of the communities that we're working with. So whether it's, thinking about, embedding more of an understanding around, say, for suicide prevention, to the work that we're doing, or finding ways of, of doing our training in Spanish, which is, part of, this push that we're involved in now in Puerto Rico. So I think it's really about finding the right opportunities and the right needs at the community level and targeting those, because I think we've got an amazing team that's really committed to this, and we can really pivot and meet those needs in the community.
Nice. Absolutely. So, and this question is for both of you. So, George, you can answer first. But what's one thing you hope that listeners will take away from today's chat about the importance of overdose safety planning and the role of training in saving lives?
I was just going to say, I think, just from my perspective, it's that substance use disorders are a medical condition that should be seen no differently than, any other condition within the healthcare space, right? And that there are treatments available, and most importantly, that recovery is possible. I think that it's really critical for us to be the conveyors of hope for those that might be feeling hopeless if they're struggling. But recovery is possible, and I think that, there are things that we can or should be doing differently. And I think overdose safety planning is one of those interventions that needs to be baselined into a lot of the work that healthcare providers are involved in. So that's sort of, that's what I want people to take away from recovery is possible.
Absolutely.
Yeah, and I think like along those lines, as far as hope is concerned, one of the messages we really push is that overdose is preventable and that everyone can play a role in addressing this epidemic. So we really want people to walk away feeling empowered that they can be a part of continuing to move the needle in the direction that we want to see.
Absolutely. Thank you. And so, where can listeners learn more about Zero Overdose, sign up for training in their area, or connect with your organization? Because I've got some ideas personally. So, I'm wondering for myself and for our listeners.
Yeah, so our website is www.zerooverdose.org. Just sending an email to us through that, we could definitely follow up. We get a lot of inquiries, through our website, and there's multiple opportunities to either get involved, and request trainings and other services through our website. Instagram, we're on Facebook, and we're on LinkedIn. So, we can actually hopefully post all those different links for folks to get involved. But if not, it's zerooverdose.org is our website. And I think you can connect from there as well.
Awesome. Awesome. Well, thank you both so much for joining us today. I have really appreciated speaking with you both. And thank you to our listeners for taking the time to join us. As always, the resources for this episode and an archive of all of our other episodes can be found on our webpage at triadhq.com/BHT. And we look forward to having you back with us next time on Behavioral Health Today.
We appreciate all the support from our community, and if you like our show, one of the best ways you can support it is by giving us a 5-star rating and leaving a review. Behavioral Health Today is a podcast part of the Triad Behavioral Health Network, all rights reserved.